Welcome, everyone, to Beauty and the Surgeon podcast. I'm Amy. I'm a nutritional therapy practitioner. I'm also a bodybuilder. And I'm here with my very springy co-host, bouncy, long jumpy. What would your sport be, Dr. Martin?
Soccer. I played soccer.
So you'd be bouncy and springy.
Yes.
Those are things I would, you'd be my very bouncy and springy soccer playing co-host, Dr. Jason Martin.
Right.
He's a board certified plastic and reconstructive surgeon.
Do they have bodybuilding in the Olympics? Do they?
They powerlifting, yeah.
They have powerlifting, not bodybuilding.
Yeah. Well, that's weightlifting, yeah. So we're going to put us on the podium, Nils. There we go. Dr. Martin's kicking a soccer ball. It's like one of those things, the characters. Your caricature would have the soccer ball.
I can't wait to see how Nils edited it.
Yep, that's going to be awesome. So
we love the Olympics. Nils' wife, Sarah, loves the Olympics. And I think the reason I like it is because of the stories, the stories of the competitors.
Well, it's cool to see countries like really put it together, the athletes, like it's super cool.
The amount of editing and production that goes into that. I mean, it's probably years of the making.
Oh, well, yeah. I mean, they plan for Olympics like many years in advance.
No, like for the video stuff. That's what I'm talking about, the coverage.
And the opening ceremony, it rained the whole time. And it was all outside. I was stressed as a video guy, just watching everything happen.
Well, I almost texted you because a lot of the cameras had watermarks on it.
Yeah.
And I was like, I'm surprised they didn't have coverage for that.
Yeah.
Maybe it was raining so
They
hard.
usually have these slides that go in front of the lens in like a frame.
Right.
And you have a couple of them in there. And then if one gets wet, you slide it out and you hand it to someone. They wipe it off.
Right.
And then you just keep replacing them when the director moves from your shot.
Right.
And it's very standard. I guess they don't do that in France. So it was weird to me because I'm like, clean your lens. Yeah.
Very simple thing. It was a beautiful ceremony, though.
Yeah. Well, so we are in the midst of Olympic season. If you are not watching this podcast and you would like to, you can find that along with all of our other social media handles right here. We're on YouTube at Jason Martin MD. It'll be in the description box below, was recently a guest on the Scott Mize podcast. It was really interesting. Scott's a really interesting guy. He used to be super into carnivore and then became a bodybuilder. And we talked a lot about body image and plastic surgery, a little bit about bodybuilding, but honestly not much, and a lot about nutrition and digestion. I think you'd find a lot of value in it. So definitely click on that link below if you're interested in seeing me on a different podcast. But today is all about you, the listener.
We love you.
Today we are answering your voicemails. 303-630-9038. Did you see I did not look that time?
She didn't look.
Well, Nils is like, well, it's definitely wrong.
It's taken 4 years.
I'll triple check. Yeah, double check that, Nils. Your voicemails, questions, and comments. So I love voicemails. We only have one. So it is the number one. It is the gold medal. We get our voicemail is the first one we're going to listen to. And then we have some comments and some questions and some other things. And don't let me forget at the end, there was one that I didn't actually include, but I do have a note. So when we get done and I've forgotten everything, you guys tell me there was something else I wanted to bring up and I'll remember.
Got
maybe.
it.
Okay.
I'll probably forget.
So our first one is a voicemail, and let's listen right now.
Hi, Amy and Dr. Martin. I have a two-part question. First question, how far apart do you recommend spacing surgeries on different areas of the body in a healthy 50-year-old? I had an extended tummy tuck and an arm lift and would like to have a back lift next, but I'm wondering about the safety of spacing to allow between those anesthesia events. My second question, I have heard you mention that you only operate if anesthesia is required in a hospital setting. I am near Nashville, and outside of Vanderbilt plastic surgeons, every surgeon that I consulted with used a freestanding surgery center. They did have privileges at a hospital, which I verified, but each surgeon told me that it was cost prohibitive unless there was a strong patient preference or a health issue with the patient that made it necessary to use a hospital OR. I would just love to hear your thoughts on that. Thank you so much, and I love the podcast.
I wish we knew this listener's name because I feel bad just saying listener from Nashville.
I mean, number one, she reminds me of my family because I'm from Kentucky and they all sound like her, which is like the best voice ever.
Yes, I love it. I am surprised.
Nashville lady.
That you had a tummy tuck, an extended tummy tuck, and an arm lift in a surgery center. That does surprise me. We would, yes, our standard would be to do that in an OR and have you spend the night. There are some amazing surgery centers, and you were so wise to make sure that your surgeons were credentialed at a hospital, which it should be a requirement of any actually accredited surgery center. You have to have admitting privileges at a hospital. So that is really good. maybe I'm thinking the Vanderbilt guys, man, they just have they got all the OR time taken.
Well, no, she was saying like besides Vanderbilt, I think.
That's what I mean. Like that they're taking up all the OR time.
Yeah. Well, I mean, there is a cost component to this, number one. Secondly,
it's not drastically different, at least around here.
Right, but it's, it's different from city to city. Yeah. Secondly, a lot of these primary hospitals really don't want the cash paying patients because they get much more money from an insurance case like a spine case or an ortho case. So there's a financial component to this, that the plastic surgeons that do cosmetic surgery, and there's some really amazing surgeons in Nashville. So I'm not going to name them all, but there's some very big names in Nashville. So I'm sure you went to one of them. That, it kind of forces the plastic surgeons into the freestanding ASC, the surgery centers. So, I mean, that kind of makes sense to me.
Yep.
And I don't think it's a precursor that you have to do these big surgeries, but a lot of these surgeries, you're going to want at least a 23-hour stay. And so all you can stay in a freestanding ASC is up to 23 hours, not 24. That's pretty much legislated. So if you had to stay more than a couple days, you would have to go to some tertiary center that would let you stay overnight.
Well, that's from check-in. I mean, when we used to do some of our bigger cases at a surgery center, it was rough. I mean, they're literally putting a patient outside in a wheelchair at 4:00 in the morning.
Right.
Yeah. Brutal. And like Dr. Martin said, that's legislated. Like they cannot, if you're going to stay past that point, they have to admit you to the hospital.
If they take Medicare or Medicaid. So
yeah. Which all accredited facilities.
I think they do. I mean, you never know.
Well, the big hospitals do.
Now there's also ORs. I know we're skipping to the second. We'll go back to the first, but there's also ORs in surgeons' offices that are Quad A certified, totally fine. They could set up nursing services for you afterwards. I guess theoretically you could stay there multiple days. I really don't know the limitations on that. So there are ways around this. And yeah, I mean, the surgeons you're visiting are absolutely correct. That's the standard these days because of the financial component. Patients don't want to pay the exorbitant cost sometimes with hospitals, even though we negotiate good rates. And then also the hospitals really don't want those cash paying patients because they get more money on the insurance cases.
So they limit the amount of time that's available in the OR.
Right.
Yeah.
So the other workaround of that is a lot of hospitals have freestanding ASCs or surgery centers that then somehow maybe there could be a negotiation to stay overnight in the hospital.
Well, that's just where they'd admit you.
Yeah.
I mean, that's kind of then the trade, and that would happen. That would actually happen with the surgery center that we work with is attached to the hospital. If a patient needed to stay, couldn't be discharged at 23 hours, they have to sign something that says they know they'd be admitted.
Yeah.
Like that's just the way it is.
So,
yeah.
But it's a good question.
Yep.
Nashville lady. So we wish we knew your name.
Let's answer the first part of your question. Okay. How far apart should we do body surgeries?
It's so hard to not do her name.
I know. I hate it. I
feel like she's a family member.
I know. I wish we had a name.
So number one, you can stage different types of body procedures pretty close together. I mean, theoretically speaking, you could do it within 4 to 6 weeks if, as long as you're kind of recovered. But you have to think about an extended abdominoplasty has had probably a diastasis repair and a long incision around your torso. And if you're doing a backplasty, you're going to be laying flat on the table. Most likely with tummy tucks, you're going to be walking kind of hunched over. You don't want to put a lot of tension on that abdominal wound. So you'd want to wait months after that to do the backplasty.
I would even say a year, 6 months to a year.
Right. Now, 3 months would be the earliest in my mind. 6 months is probably correct. And then as long as after that as you want.
Well, because like you said, you don't want to, why not wait the extra time to make sure that you're not compromising your second surgery? That would be my concern. Because as you know from having the tummy tuck, you were pulled very far forward. You want them to be able to pull as hard as they can in the back as well. And if you are compromising that by still needing to be in a slightly
dorsal lithotomy or hunched over, extended or whatever prone position, then it would limit maybe the surgery a little bit, but also the recovery too.
Be rough.
Secondly, you do not want to be recovering when you're lacking mobility because you're still kind of gingerly walking around because of the tummy tuck.
Yeah.
But if this is theoretically say you did a tummy tuck and after that you wanted to do the brachioplasty or your arms.
Sure, you had the arms done.
I know, but I'm saying theoretically speaking, that might be a situation where you could do it within 4 to 6 weeks or even 8 weeks.
Oh, yeah.
Because they could put you in a beach chair position and do your arms at the same time if they had to.
Yeah, that would be totally
It's really dependent on the surgery, not just carte blanche, like you shouldn't do surgery near each other.
And that was her question too, like spacing of anesthesia. I mean, we have patients who have a medically necessary procedure a couple weeks before they're having surgery with us so that they can kind of try and compress their downtime. If they needed orthopedic surgery and they're also having surgery with us, they'll do it within a few weeks of each other.
The other reason that we try to do as many surgeries as possible is we have an episode, I don't remember which one, but Nils could have find it, hopefully. about general anesthesia and the neurologic effects on that on people over 60. You're 50 years old, but you don't want to load up on too much anesthesia. So it'd be good to kind of group those together as much as possible. But extended tummy tuck and brachioplasty is a decent amount of surgery. Yeah, I wouldn't do the backplasty with that.
No. Well, that is one other caveat that I would throw in here is just making sure that you're really nutritionally optimized. Go back and listen to our episode about supplementation around surgery 2.0, because that's a lot of tissue healing that needs to take place. I mean, if you think of the inches of incision that is, it's a lot. Totally. And then a backplasty is also a lot of incisional area. So I would want to make sure that you had enough time to really bounce back, that your energy was back, that you felt like you were really in a good place nutritionally, that you were eating properly, just to make sure that wound healing is optimized. Because again, why do something too quickly when your body's kind of already compromised?
I don't think people realize how much your back is kinetic. Mm-hmm. So when you reach your hands across, putting tension up, down.
Yeah, up, down.
Hunching over.
Twisting, turning.
Hunching over.
Even turning your head.
Especially the thoracic area in the back, which is where you do a backplasty, like where your bra line goes across.
I think she means the lower body.
She said backplasty.
She said back lift, but I think she means...
Oh, okay, in the back.
Yeah, I think she means
I love her even more now.
Like extending the tummy tuck
No,
around.
I love her.
Yeah.
I love her. Thank you.
I mean, I could be wrong. I heard it as I was thinking it was more of a butt lift, like a back.
No, she's like, just lift the back.
Yeah.
Honey, lift the back.
Yeah. Either way, though, I mean, that's either way. There's still a lot of incision in that. And your body, I mean, our spine twists from top to bottom. So that's why I said even turning your head is going to impact your spine in the back. Yeah. So it's all connected. I loved this question.
Oh, it's such a good question.
Thank you so much for leaving us this
Thank you for the voicemail. We love you. Please send Amy your name and we'll give you a shout out. Maybe you don't want to give us your name.
Yeah, that's fine. You can be anonymous. Okay. You can be voicemail
Anonymous
from Nashville.
Anonymous Nashville.
All right. So this was from Instagram, A Life in Oil. It was on our Instagram post. So it was a before and after of a rhinoplasty. And they said, is this surgical resection difficult to perform, doctor?
I mean, are you questioning, do I feel like it's difficult? Probably not for me. I don't understand. What are you saying?
That's the question. I mean, is it difficult to do this type of, is a rhinoplasty difficult?
Oh, is a rhinoplasty difficult? Mm-hmm. They can be. Actually, it's one of the more difficult surgeries we do. And that's why if you watch our rhinoplasty episodes, I know we're up to 3, but right here, just pick which one you want. You really need to find an expert. There's 2 subspecialties that do rhinoplasties, plastic surgery, which obviously I'm a board certified plastic surgeon, and ENTs. Some OMF surgeons do it, but that's primarily the ENTs and plastic surgeons. And not every one of the plastic surgeons or ENTs even do rhinoplasty, so it's very subspecialized. And it can be a hard surgery depending on your presentation. But if you go to someone who does it all the time, they have a cadence and they're facile with the surgery, I don't think it's quote-unquote hard. I think in most cases it's doable. I don't struggle with my rhinoplasties. But also I have a lot of experience doing them. Yeah,
you've got to have the eye. And we talk a lot about, I think it's in part 2 of our Everything You Should Know About Rhinoplasty, we talk about the tent. Yep. And the tent analogy of the nose, like being able to really visualize something in that, kind of all dimensional, spatially aware, I think is what makes it difficult.
When you say resection, which is a medical word, which I find very interesting, resection for rhinoplasties are usually 2 areas. It's either on the tip of the nose, the upper part to narrow it, or the profile, which we call the dorsum. So rarely do you take other stuff out. Maybe you'll take some out from the septum, the temp pole that holds up the midline of your nose between your airways. Sometimes you'll do that. Sometimes you'll take out alar tissue for a weir excision, but those are the 2 areas. And dorsum reduction or reducing your profile is pretty standard. That's not going to be difficult to someone who does it on a regular basis. The tip can be a little more difficult, especially for redos and especially for people that have congenital issues. They were born very differently. They have different anatomy. That sometimes could be hard. The weir incisions around the edge of the ala, those are not hard at all. And then the septums, I mean, that's not really plastic surgery. That's usually, unless you're getting cartilage, that's usually more airway stuff. And we'll defer to the airway surgeons on that.
Yeah. So great question. I loved it. And it was from an older post, which I love that people comment on the older posts.
A Life in Oil.
Yeah. So this one is actually just a comment. It's from blah, blah, blah. Blah, blah, blah.
Oh, she's back. I love her. Yeah.
I know. I feel like it's been forever.
Our Norwegian friend.
Yeah. So she said, what a coincidence. The day you released this, she's talking about our rhinoplasty episode. I did a septoplasty because of a deviated septum and turbinates. I know it's not a rhinoplasty, but now that I look at myself in the mirror, it could have been the same. So I think she feels like there's some changes to the nose.
Yeah.
I just love it. So
okay, so we missed you, blah, blah, blah. But
we have missed you.
I don't think you went anywhere. You're probably still listening. And so happy you had a septoplasty and the turbinates. The reason you have a septoplasty and turbinates for the listeners is because of breathing issues. Airflow through your nasal airways can be obstructed by deviation or curvature in your septum. That's the temple that holds up the nose. And the turbinates, which are on the outside, and what are the turbinates doing?
They're like humidifiers.
Yeah.
Mm-hmm.
So if you reduce the size of those turbinates, those outcroppings, and you make the septum more straight, then you have less obstruction of airflow, less resistance. And they always equate it to the flow of water. And we're in Colorado, people whitewater raft, and it creates eddies or circulating water when you're going over whitewater rafting. And sometimes you can get stuck in those, and those can be a problem. Those can be dangerous. It's the same thing with airflow. It has kind of disrupted airflow can create eddies, and you don't get this truly resistance-free airflow, and you can feel the obstruction. Yeah. So
that's what CPAP helps with.
Right.
It pushes that air straight in. Mm-hmm.
So if you do a septoplasty, you take out some of the obstruction of the airflow in the nasal airway. The other things that people do, and maybe blah, 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 had this, is that they put in something called spreader grafts, which opens up the nose. We've talked about this before. I'm taking off my glasses. Don't look at my eyelids. And you pull out on your cheek, and you can feel the air going better.
It's those the breathe right strips.
We've talked about that before.
Pops up that tent.
Yeah. So those are the three things. But why would the nose look better? So if you didn't narrow...
Or different. She doesn't say better. She just says...
Okay, she feels like maybe it was kind of like a rhinoplasty. Yeah. That's because if you have a crooked nose or some sort of deviation of your nose and you do a septoplasty, your nose may be more straight afterwards, literally. And specifically from the upper third, which is bone, the middle third is cartilage, and the lower third is the tip cartilage. Usually it curves to the left or right. It can go more straight, and your nose can actually look aesthetically better.
Yeah, it can be straighter. She watched this the day after having surgery. It's going to look weird for a little while.
Oh, maybe it's tongue in cheek. It's because she does have a sense of humor. Maybe she's saying, "Oh, it looks like I had a rhinoplasty, but I only have my septum done."
Exactly. It looks like she had a rhinoplasty. Okay. She got the black eyes. You got all the things. People are going to think you had a rhinoplasty, but you had a medical surgery.
Just for your airway.
Mm-hmm.
Bummer.
Yep. But thank you, blah, 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 for commenting. I love that you're still listening. Love it.
We miss you.
Yep. All right. Let's take a quick break, and we've got some more fun questions coming.
All right.
And we're back. And you're back.
We're back.
Let's get some more questions. All right. This one is actually, we are going to play a video. This person just wrote, this was from Non4M30. Please make a CC episode.
Oh, we got that.
Yep. And this was on breast augmentation 2.0. And we've actually done this as a myth. And the myth was actually, we pulled clips into the myth episode from a previous episode where we talked about more. So
but then you talked about it again.
That's what I mean, time. In the myth episode.
In the myth episode.
Yes. So this,
I feel like we're breaking down all the walls of reality.
Yep.
Multiple dimensions, Dr. Strange.
So for you, Non4M30, we are going to play this clip now.
You should get the same size implants as your friend, sister, your cousin, your friend's cousin's sister,
your boyfriend's
or this one
sister.
woman that you saw at the gym. Yep. You're not sure what her name is, but
Girl
her breasts look good.
So
which drives me effing crazy. Please, for the sake of God, we don't mind comparisons. We don't mind you showing us examples of things you like, and that's your aesthetic vision. But saying that your so-and-so friend who you barely know got 330 cc implants from Mentor, moderate plus projection, and that's the ones you want. I just want to poke my eyes out to even saying that. So
we have so many great episodes where we talk about implant sizing. And Nils, if it's not too much trouble, and I didn't ask you this ahead of time, would you mind inserting the clip right here where I talk about implant sizes? It's about to show up right now. Here it is.
Here it is.
So this is what I do with patients.
You
when
have to watch the
in.
YouTube channel. I'm sitting here very uncomfortable. She moved everything.
So this is a 310.
I'm going to put it right up here.
This is a 310. Okay. So these two implants are the exact same CC size. Try not to make Nils' expensive computer fall off. If it was the Chromebook, I wouldn't care. So these implants are exactly the same size. They are both 310 cc's, but as you can see, they are totally different implants.
So this one has a very wide base. The one that's not as projecting, and the one that is more projecting has a very narrow base. What is the difference on these bases? Probably a couple centimeters.
Oh, for sure.
Yeah.
And then let's like really confuse matters by putting this 350, right? So these are actually 310s, I should say. They were, to be precise, these are 310
That weirds
cc's.
me out because the 310 looks bigger than the 350,
Correct.
the one with the narrow base.
Right? But really, I mean, if you look at these two implants, these two implants, a 310 and a 350, have the exact same projection,
Yeah.
but very different bases. You know, if you hold them this way, you can kind of see that, like this one's taller. So these project the same. This one is the same amount of cc's as this one, but it has no projection
You're
at all.
blowing my mind,
Right?
man.
So,
Stop it.
So let's just assume, Nellie,
That's
you're
like
all.
an MC Escher kind of like when
Yeah.
you're looking at it.
It is. It's like the fork. Is that how many times are on the fork? Let's assume that you have this is a moderate projection implant. This is a 310. So this is probably similar to what you have. This implant is a 425. Okay. Has basically the exact same diameter at the base, but look how much more it projects.
Yeah.
So it projects almost the same as this little guy, the 310, right? Same amount of projection. So if you have the 310, going up to a 425 isn't going to change the projection of your implant at all. All it's going to do is add width. Whereas if you have the 310 that's this one, it's not going to change the width at all.
It's going to change the
It's
projection.
only going to change the projection.
Yeah, so interesting.
So this is why you see that like 420, I mean, like going up, I think you need to go up to at least a 450, which you can do keeping the exact same diameter, just increasing the projection.
And the diameter matters because the pocket's already been established by the surgeon. And so you think about it, you don't want to go, you probably don't want to go wider. Probably that implant fits you. So your only choice is to have a more projecting implant, which will look a little more augmented if you're of normal weight or lower weight.
But yeah, but it also might not, and it kind of seems like you would like a little bit more to balance out your hips. So you probably need the projection. Now, if you have, if like Dr. Martin said, if you have this implant that's very narrow, to go up to an implant that's very, very wide, you'd have to re-dissect the pocket a little. But just to go from these two, right? Going from your 310.
By the way, it's very hard to go from a wider implant to a narrower implant. And that's where you get into grafts and doing pocket work, which is definitely more expensive and more involved.
This.
Yeah, I've never seen you do that. That's actually really interesting.
This is what I do with every patient who comes in for breast augmentation with us. So the myth, we do say that on our episode about implant selection, is that everybody wishes they'd gone bigger. That's not true. Like, it's not if you're sized correctly in the beginning. And that's why expectation is key. If someone is saying to me, and there have absolutely been times where I've pushed a patient to an implant that they're like, this is way too big. A month and a half after surgery, they're like, and I say, how do you feel about your implant size? It's perfect. I'm so glad you pushed me to that, because that comes with understanding the base, right? These two implants, if someone's like, oh, I don't want to be anything bigger than 300, but you see that this is going to basically look the same on two different people.
Yeah.
A 425 and a 310 is going to look exactly the same on a very petite person and a moderately sized person, even though they're different sized implants.
Yeah.
You get the same amount of projection.
Yeah.
It's just which fits.
Yeah. And I think that that's really important. Also, when we say we push people bigger, it's only 10% bigger. So it's the reverse of what we said before. When we give people ranges, it's usually pretty close to each other. So we're not saying, hey, you could do a 275 or a 450.
No, but there are patients who come in like, well, my friend has 300s and they look great on her. I'm like, right. And your friend this is your friend. Your friend is 310, right? To look like your friend, you have to do 425.
Every time I see implants samples, I think about a time that a patient came in and I handed it to her so she could feel it, and she handed it to her 2-year-old, and he started like playing with it like it was a doll.
Yeah.
And I was like, this is so inappropriate.
Well, this is honestly, like a lot of the time, this is what my desk looks like.
Yeah.
Has implants all
we have
over
a weird job.
Yeah, I got a
very
weird job. Like my job is weird.
Yeah.
So, and this is to one more point, and then I'll be done with the implants. So 350, 425. This is the 75 cc difference that you think would make a difference. You see how it makes none.
Hopefully they can see that at home. Yeah.
Literally no difference. These implants project about, I think, 1/10 of a centimeter different.
Yeah.
The only difference between the two is a little bit of width.
That's crazy.
So to just size up in the same profile of implant, 75 cc's, you would literally, on most people, unless you were extremely petite, you would never notice the difference in 75 cc's. You just wouldn't.
Yeah.
So you can see there, that was actually a question from a listener where she was asking about implant sizing essentially, and it was just the only way to describe it was to show it. So the big myth with implant sizing is that there is a size that is going to give you a specific size. There isn't, because your body is different than everybody else's. So the same size implant, and I
feel like Mr. Rogers right now. You are special. You are an individual.
Special. I go back to this. We did surgery on twins. Identical
twins. This ain't no joke.
Different size implants.
Beautiful, young, perfect young women. They were identical twins, identical.
Yep. And they had different size implants. Now, granted, they had slightly different vision. They didn't want the exact same thing. So even two people, even if they had one of the exact same thing, another day we did breast augmentation surgery on 4 patients in a row. 3 of them got the exact same size implant. Look totally different. Totally different. One of them started out as a very petite, barely A. Another one was already a D. So volume is volume. It doesn't change the breast you have. It adds volume to the breast you have.
Right.
So based on your breast size, your shape, you saw that in the video, the diameter, your implant is going to be perfect for you, but it has nothing to do with the size of anyone else in their implant.
Right. And we start out with the width of the chest, right, Amy? That's the main measurement. And then we decide the projection from there. And with these newer implants, you have a little bit of projection, moderate plus, a lot of projection, and a lot of projection. And that doesn't even get into the form factor of these things and the build of these implants. So you start with your width, and that's where if you're looking for a natural breast augmentation, and then you go from there. And that's the key. And that could be different on like 2 people that look similar. If you look at their chest measurements could be totally different.
Yep.
So we do appreciate the fact, and you as a patient need to look on the internet, see what you like, see if you like natural augmentation, more augmented appearance, whatever you like, so you can speak.
I wouldn't search though for breast augmentation pictures. Just find pictures of breasts that you like.
It's weird. Like when people do that, they always come in with pornographic pictures.
And I say,
and it's
do you
like
want
you're
to look
looking
like
at
this?
the person and talking to them. There's no relevance to them. They're not. That's not them. And I was like, I wish.
Do you want a 700cc implant?
No.
No.
They think they want it, and then you explain to them what that would look like. Like, oh, I don't want to look that, because most of the time a huge implant just makes people look fat, especially
petite people.
Yeah, if they're not tall. So, yeah.
Yeah. So your implant is your implant, and own that. Get your perfect implant.
And you can tell your sister that myth was busted. So that was seriously an Inception situation. We went from an episode to an episode to an episode, back to this episode. Now we're back here.
We're back here. And in the oldest episode, we're literally wearing the same things we're wearing right now.
I know.
Even though that episode was from 6 years ago.
We had the TV behind us. We had the microphones on the stands.
17, 18.
Yeah, my hair looked good. I didn't get a haircut. Yeah.
Yeah. So we love this. Thank you for leaving this comment. We do talk a lot about CC sizes on all of our implant episodes. I think the reason we didn't talk about it a ton in that breast augmentation 2.0 is because we had talked about so much in the past, but I really appreciate you commenting and bringing this back. If you have additional questions about CCs, please leave them in the comments below, and we can always deep dive it some more. And we will. We talk about breast aug all the time. Yeah. All right. This one also on the breast. This one came from Patricia Moscato 6586 on YouTube on our mastopexy episode. And this was the whole comment. And I think she meant not your back, not lifting your arms. I wasn't quite sure how to respond to this. And that's why I put this in here, because I think what your question is maybe how long do you have to sleep on your back and not lift your arms? That's what I got from this maybe. So that's what I'm going to go with. Yep. Nils too. So yes. We do want you sleeping on your back. Your surgeon might be different, but at least the first 4 weeks, maybe even 6 weeks. And part of that is, you have a lot of incisional area. What you don't want is just pressure from one breast on top of the other kind of all night long. And it's not very comfortable to be moving back and forth at first. Needs to use your arms.
I think she was trying to say on your back, ?
Yeah, on.
Not non. Not lifting your arms, ?
Mm-hmm.
Yeah. Okay.
Yeah. And the lifting your arms, now if you did not have an augmentation with your mastopexy, your restrictions on moving your arms are probably going to be lifted a lot sooner. So really just 2 weeks where you have a lifting restriction of about 8 pounds. We want you kind of keeping things close, T-Rexing it a little bit. But there's no muscle involvement. So once that incision's kind of healed, you're usually pretty good to move your arms.
Right.
Yeah.
Depending on the mastopexy you had, the type of incisions and stuff, that can change it. But yeah, a couple weeks is all you need.
It's really, a mastopexy alone is a super simple recovery.
How long do they sleep on their back with a mastopexy? Just out of curiosity.
At least 4 weeks, maybe even up to 6, just again, depending on the type of mastopexy you had, how much breast tissue you have, those kinds of things. If you had an augmentation, it would be 6 weeks.
We do a lot of fat transfer with mastopexy when people don't want implants, so that may limit you even longer.
Yeah, that would be the 6 week
also
mark.
from exercise too, and elevating your heart rate and blood pressure.
Yeah. But truthfully, I mean, really, a mastopexy is, I think, as scary as it seems, because it does seem like, oh, you got this incision in a very delicate, sensitive area. There's not a lot of pain with a mastopexy, and our patients recover extremely quickly.
Very quickly.
Can't swim for 6 weeks. Insert Olympic swimmers here. Right? The swim dancers. So thank you so much, Patricia, for that question. It was great.
It's trolling. It's trolling. It's insidious.
All right. So this one was also on YouTube.
I cannot answer this, but I will tell you that I saw a patient who was drinking turmeric tea.
You have to ask this. Not everyone is watching, so you have to read the question
I'm sorry.
first.
Excuse me. I heard turmeric robs your body of iron. Can you check on that for us? Thank you for both of this videos.
Thank you both for this.
Thank you both for this video. Sorry.
Who's dyslexic?
Okay. No. Many blessings to you. And that was from D Kisser 252.
On YouTube on our supplementation around surgery 2.0.
Yeah. So by the way, the patient was drinking turmeric tea, which I was like, I know all about that. So does it rob your body of iron?
It can. In extremely large doses, yes. Now, if you have iron deficient anemia, I would not recommend supplementing with turmeric. I also would recommend checking all of your supplements with your doctor. And this is why I struggle with giving recommendations, even though I do on this episode give recommendations about supplementation, because people don't follow instructions, so they take too much. I mean, you would have to take a very extreme amount of turmeric and or be some type of iron deficient anemia.
Okay, so a lot of women can have iron deficiency anemia, so that's not uncommon. So what is the nutritional answer for iron deficiency anemia if you saw a patient like that? Now, you're not their doctor,
right.
Just your recommendation.
No, I mean, from a nutritional standpoint, I would have them. There's two things I would recommend as a nutritional therapy practitioner for that patient to do. I would have them increase their consumption of not only meat, but also organ meats. Yep. Supplementing with taking, things like iron is extremely dense in liver. I know people don't love eating liver, but that's the very first thing I would recommend is you can do supplementation, like you can get liver capsules that are from pastured animals. The other thing too, you can actually buy, they're really cool, a little iron stone essentially. And you carry that around with you and it actually leaches through your skin. Increasing your use of cast iron cookware would be the other thing. So from a nutritional standpoint, there are great things you can do to get iron. If you have an iron deficiency, especially if you have iron deficiency anemia, like you should be getting that.
Then you can take iron supplements.
You can take iron supplementation. They can cause constipation and other things. And you need to be having that checked. I mean, that's always my concern with recommending supplements is that you're going to then over supplement. You can take way too much iron pretty quickly. It's in a lot of things. It's in your multivitamin and then you're adding in a multivitamin or a supplement. Like you could get too much. Turmeric in the doses I recommend for a healthy person who does not have any issues with iron absorption is going to be just fine. You would have to be really consuming a lot. I mean, look at a huge billions of people have turmeric as a main ingredient in their diet.
What?
India.
Oh, of course.
Yes.
I'm so American.
Yes.
Yeah.
I mean, it is huge.
No, yeah, for Indian food.
Yes.
Yeah.
So
which, by the way, that's our favorite thing to cook at home, and like turmeric and coriander are the two ones we always choose.
So these are found in nature. I think the poison is in the dose.
I can be so smart and so dumb at the same time.
I mean, it's true.
But I was thinking about supplementation. I wasn't thinking about food for whatever dumb reason. I was thinking there's millions of people drinking turmeric tea.
Yes, there are. I mean, it's in chai. It's in so many things. I mean, the poison is in the dose, right? Even water is toxic at some level. Yeah. If you've ever been diagnosed with any type of iron deficiency, you definitely should clear taking any supplement, including turmeric and so many others, with your doctor before you start taking them.
Exactly.
So thank you, D. Kaiser, for your question. That
D. Kaiser 252.
Yes. All right, I'll let you read this one. But first you have to read it and say who it's from.
You read it. You go ahead.
Well, this is from Anna, IY6CP on YouTube. Everything you need to know about blepharoplasty. Hi, I had an under eye bleph and the surgeon made it way down below the lower lashes. She means the incision. Made the incision. It is the incision below the lower lashes because I had a lot of wrinkles.
Okay. So
he is a great surgeon.
Oh, I'm sorry.
But I haven't seen anything that looks like this. They said it will look like a wrinkle and it will turn white. I couldn't get the one you're talking about because I had no fat. So that was the one that's on the inside of the eye. You guys are great.
Well, thank you very much, Anna IY6CP off of YouTube. But so I have a question about her question. So is she saying the incision is not right underneath the eyelashes, or is she saying she couldn't get the transconjunctival fat removal?
Both. She's saying that the incision is way below the lower lashes and that she wasn't a candidate for, fat only.
Yeah. So
she needed skin removed.
Right. You need what you need. Like if you come in, if you don't have herniated fat, like I have on my lower eyelid, Amy has a little bit too. Yeah, that's where you go from inside the eyelid. That's called transconjunctival approach. We do that every week. Just make small little incisions. You take the fat out. That's great because you don't have any external incisions. But if you have extra skin on the outside, you're going to also most likely have an incision right underneath your eyelashes that goes out to your crow's feet area. So,
and sometimes it does extend into that righted.
Yeah, and it can extend out into the crow's feet. But what you're saying, Anna, it sounds like that it's farther down from the eyelashes, which would not be normal, unless I'm reading this question correctly. Now, incisions on the eyelids, no matter what, do heal well. They're correct.
Well. Mm-hmm.
They might look like little white lines, which in some cases, especially for people that hypopigment, that could be a problem. But for a woman, even men, you could put a little some sort of pigmented makeup or cover on that, and it would look just fine. But there's no way to remove or to tighten that skin on the lower eyelid enough unless it's only mildly redundant. If you have moderate to severe extra skin on the lower eyelids, it has to be removed with that external incision.
Well, and I think it does, and we do this too, it does kind of almost need to be chased out a little bit in most cases, because if you don't, you can get a very pinched appearance at the corner of the eye. And we've seen that in patients where it almost ends up looking like a little divot where they've tried to just end it right there. And then they get this little pocket, almost like a little deficit. So we will often, and even sometimes with the uppers, we'll have to chase it out just a little bit if they have really intense wrinkles. And it does heal extremely well. Not knowing how far you are from surgery, I mean, sometimes that incision can look like it's lower than it actually is because the whole eyelid is being slightly pulled down from inflammation. So I think that could be part of it too. Like it might look like she might feel like her incision is sitting really low right at first, but once it heals and that lash line kind of perks back up, it'll look appropriate.
When I do blepharoplasties, and Amy knows this, we most of the time do remove fat because most people have herniated fat, at least in our patient population. We don't remove all of it. We don't want to clean people out too much. And that goes from the inside. And then the outside, you would do the incision underneath the eyelashes. But the inside incision can cause something called chemosis, or swelling of the conjunctiva, that kind of covering on the inside of your eyelid. And that can evert the eyelid, and also the swelling on the eyelid itself from the removal of fat can cause ectropion, or lid distraction, pulling it down. And those can lead to the scar on the outside, or the incision on the outside, looking like it's lower than it ultimately ends up being. I saw a lady, it was a couple weeks out from a surgery I did, eyelids. She looked amazing, but her scars were artificially a little lower because she still had a teeny bit of swelling on the inside and ectropion.
Is that the day you asked me about the Tobermex drops?
Yeah, that's Tobermex drops what we use. Yeah. But that's pretty unusual. Yeah. So,
and it always resolves.
Yeah. If it's really far down, I can't explain that. That's not a surgery I do, but hopefully you're looking good.
Yeah, I would assume it's resolved, Anna. Yeah. So thank you so much. This was a great comment, and we appreciate that you listen and that you think we're great. I think you're great.
I think you're great.
You're great.
No, I think you're great. I think Nils is great.
Sarah's great.
The Olympics are great.
Yeah, you know who else is great is you, the listener, are great, because we could not have had this episode without you.
Right.
You had to listen. You had to comment. So there's one more, and I remembered. So on a really recent episode, someone made the best comment. It said, "Amy, let's talk about SIBO." And I love that they used a throwback to our episodes. We used to do a lot of let's talk about this. Yes, I absolutely will. I'm actually enrolled in a program right now. It's a very intensive, actually, GI mapping course, because of course I do know about SIBO, but I don't feel like I'm an expert in it by any means. But I am doing this really involved GI mapping course for the next 6 weeks. So once that's over, I'm absolutely going to do an episode about what the GI map is, what it does, how you use it, what it diagnoses, what it treats, blah, blah. Yeah. So yes. So that's coming.
I feel like I'm getting that test at some point.
Oh, I'm doing it all of you. I'm going to make you poop in this little jar for me.
Yeah, I know. I've been avoiding that with Amy for a long time.
That's not in my job description.
Yeah.
Like, hey, Nils, I'm going to send you home with this.
Nils, I need your poop.
Yep.
Give me your poop,
I need
Nils.
your poop. I need to know what's going on in your GI, in your gut. So that is coming. And I appreciate the comment. I'm sorry. I saw it after I sent the slides to Sarah. So I got you. I heard you. It's coming.
I really like the double inception part of this episode. So
I was wearing that same shirt.
Yeah, I know. So I think we need to do more of those, because that kind of got into my feels a little bit.
The multiverse is hot right now. So right. Yeah.
Yes. But other than that, Dr. Moore, you got anything else?
No. That's it.
I appreciate everyone for listening. Again, we could not have done this episode without you. So you are our VIPs. You are gold medal winners. You're number one.
I mean, we got blah, 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 blah.
To come back.
Yeah, to come back.
Yes. And if you're interested in hearing me on a different podcast, again, that link is below. It was the Scott Mize podcast. It was really fun. Here are all of our social media handles. You can also leave me a voicemail, please, and leave your name if you want. If not, we'll call you Nashville lady. 303-630-9038. Yeah, you don't have to give me your real name. I'll call you whatever you want.
Yeah.
Within reason. And we do appreciate everyone for listening. Give us a subscribe, a like, share us with a friend, and we will see you here next time.
See you later.